خلاص.
بسم الله الرحمن الرحيم وصلي وسلم على سيدنا محمد وعلى آله وصحبه أجمعين. Today, inshallah, we'll have very interesting talk by our friend and brother and colleague, Dr. Ahmed Tayseer. Ahmed Tayseer is really working as the hard working guy as the milestone for our donor kidney transplant workup. And he follows really all our patients who donated and those who are working to get donation, either recipient or indeed donors. Ahmed has been working long experience both in Egypt and Oman now. And inshallah, today he shall shed some light on very interesting case. And I would like to invite Ahmed, and the floor is yours, Ahmed. Thank you.
Thank you very much, Dr. Isa. First of all, I would like to thank everybody, of course, starting with Dr. Isa and all the board members of the OSNT and all my colleagues who have honored me and attended this meeting. So I know most of you are busy, and I was told today and yesterday by many people, please try to be summarized and to be focal and to the point. So, actually, in the kidney donor clinic, we deal with the pair who comes to our kidney donor clinic to go for a kidney transplant, as if we are going for a journey. So, for every patient who comes along with his donor, or even without a donor, we pack our luggage and we start the journey. So, for this talk, we're going to discuss a common incidental finding. Actually, it is very common that you can find in your workup for a kidney transplant. So we'll start. So this case was for a 39-year-old male patient who came to our clinic to undergo assessment for going for a second non-preemptive living-related kidney transplant. So this patient, he's a known case of end-stage kidney disease on regular hemodialysis, and his native disease is a biopsy-proven FSGS, um, um, secondary to a steroid-resistant nephrotic syndrome since he was very young. I think since he was like 14 years. So this patient had his first living-related kidney transplant in 2005, and the donor at that time was his father. And then he resumed hemodialysis in February 2024, achieving a graft survival of around 19 years. So for this second transplant, his potential kidney donor was his brother, who is 37 years old. He has no past significant medical history, no significant comorbidities, no contraindications whatsoever about going for kidney donation. His BMI is 28 and his creatinine clearance is fine as well. And the patient was lucky because the HLA tissue typing was completely matched for the patient with his donor. And all of a sudden, when we had a CT UT for this donor, it demonstrated an incidentally small angiomyolipoma in the right kidney, and its size was around 2 to 4 millimeters. And we confirmed about this finding. So we were sure about the diagnosis with a very characteristic radiological finding. Okay. And this is on your right-hand side at the top. It is a picture of the histopathology of angiolipoma, and it is very characteristic for its high fat content over there, and those spindle-shaped smooth muscle cells. Okay, so how did we react? It was a surprise, and I was wondering, so what I'm supposed to do in this dilemma. So should I reject this donor? This is a question. So it could be any correlation between the patient's native disease and this finding in his brother. How are we going to assess this angiomyolipoma? And was this angiomyolipoma a part of tuberous sclerosis? I mean, if we went deeply and investigated this donor, could we find other clinical evidence of tuberous sclerosis? And one of the questions as well was, considering going for this graft, if we took this graft with this angiolipoma, could considering mTOR inhibitors as a part of the immunosuppression protocol the patient is going to receive could be beneficial, adding any role by any means for delaying the progression of this angiomyolipoma. So our plan was, as you can see, that we worked on two parallel lines, donor evaluation and recipient evaluation as well, so that by the end of this evaluation, we can answer this question with it, which is it contraindicated to accept donors with angiomyolipoma? Okay, so the first step that we evaluated the angiomyolipoma itself. We evaluated its size, its site, any associated cysts in the kidney to end up putting it in a proper definition about is it a sporadic angiomyolipoma or it is a syndromic or tuberous sclerosis complex associated angiomyolipoma. This was like the first line. The second line, again, is there any correlation between this donor's angiomyolipoma and the recipient native disease? And the third line was about the possible interventions that we can consider while, of course, ensuring, which is our priority, of course, ensuring the donor and the recipient safety. So at the end, you can conclude that there is no like a straight forward answer for this question. So again, we go for a case-by-case evaluation. So we went in two parallel lines, as we said before. So considering the recipient evaluation, we knew very well the native disease of our recipient, which is a steroid resistant, sorry, it's not steroid responding, steroid resistant nephrotic syndrome, a biopsy proven FSGS. The patient had no history whatsoever of any seizures or any kind of any developmental delay. And of course, we clinically examined him. Of course, we do know this patient. Coming to the deep clinical examination for the patient, so there was no any skin lesions whatsoever, especially for those skin lesions that are very popular in tuberous sclerosis, considering angiomyolipoma as a part of tuberous sclerosis. And even we did a fundus examination again, and still it was completely free. Part of our radiological workup for the patient is doing CT. So his CT abdomen was completely free. His even CT lung was completely free. They were irrelevant for any significant lesions, any angiomyolipomas, any cysts, any pulmonary lymphangiolymiomas. And this is again for the recipient. Going to the donor evaluation, so again, we did a very deep clinical examination. And again, for the donor, there were no skin lesions. His fundus was completely normal. There was no history of any seizures or any abnormal activity, any cognitive dysfunction, any developmental delay. A PET-CT also, it did not reveal any relevant brain lesions, pulmonary lesions, cardiac rhabdomyomas as well. And so again, we can end up with putting the angiomyolipoma in its proper definition. I mean, what kind of angiomyolipoma is this patient having? Okay, and again, at the top of the picture, this is a very nice picture. It's very descriptive, angiomyolipoma. On the left-hand side of the picture, at the left corner, you can find the fat cells, and all over smooth muscle spindle-shaped cells, and those blood vessel walls, which is abnormal vessel walls. And that's why one of its consequences is aneurysm rupture. And it's actually a very clinical consequence because angiomyolipoma is considered one of the most popular causes that can cause retroperitoneal hemorrhage. So this angiomyolipoma has fulfilled this criteria. Its size, it is a small one because most of the literature is considering a cutoff of 4 centimeters. So it is a very small one. As we stated, it was around 4 milli. So it is less than 4 centimeters. It is unilateral only on one side. It is asymptomatic. it is in a male donor, and we will come about the sex difference and its influence on angiomyolipoma growth and development. And there were no associated renal cysts, because an association of renal cysts with angiomyolipoma could be very highly suggestive that this angiomyolipoma is a part of tuberous sclerosis. So at the end, it is a small, asymptomatic, sporadic angiomyolipoma and not a syndromic associated angiomyolipoma, particularly for tuberous sclerosis. So we went and we spoke with the multidisciplinary team, including everybody, including the nephrologist, including the radiologist and the urologist, of course. And we summarized the case to them that provided that we do not have another available donor for this patient, we have a donor who's having a small, isolated, sporadic, asymptomatic angiomyolipoma. So these are the possible interventions that, if you went through the literature and most of the studies, case presentations, they were almost discussing these options. The first option was to leave it in situ, leave the lesion in situ instead of doing any excision. If you have the suspicion that you're going to cause a great damage, if there is a suspicion of or risk of causing intraoperative bleeding and eventually damaging the graft during the procedure. This was an option. Another option is going for in vivo excision. I mean, before going for donor nephrectomy, at the side of the donor, they do excision of the lesion. Another option was going for ex vivo excision after donor nephrectomy, and they call it bench tumor excision. And the other option was transplanting the graft with the angiomyolipoma in block, again with the consideration of the use of mTOR inhibitors post-operatively along with the radiological follow-up. And the last options, and some of the literature would consider that this option is the choice of modality to manage such cases, which is angioembolization. Okay, so after we reached up at the decision that we are going to take this donor, we had a very long talk with the pair, the donor and the recipient, and we explained the whole situation to them and all the drawbacks that could be expected. So in addition to the routine consent procedure for a live donor renal transplantation, the pair were also consented for a rupture of the angiomyolipoma, because as we said, it is a very vascular tumor, though yes, it is a benign tumor, but still very vascular. And as we said, because of the abnormal vessel wall, it is very liable for rupture and for the formation of aneurysm that can easily rupture and cause significant bleeding. We also consented them and updated them about the possibility for malignant transformation, even though it is not of a great incident, but it is existing, and about the possibility of causing any graft damage during the procedure and ending up with no transplant and even losing the graft without adding any value to the recipient. Also, we emphasize to them about the necessity of post-kidney transplantation and post-donation imaging follow-up and surveillance for the angiomyolipoma increase in size, number, and malignant transformation, because actually angiomyolipoma, either the sporadic type and also the tuberous sclerosis associated type, it increases in age and number with age. So it is very important, the surveillance, which can be easily done by any radiological modality that is available, even up to ultrasound, it's very good and very conclusive. And also about reporting any abdominal pain or flank pain or hematury. So they understood, they agreed, and they decided to go that they will go on. So the pair was approved for kidney transplantation, again, provided that we are at the right door. We have approached the case in the proper way. Again, it is a small, isolated, sporadic, asymptomatic angiomyolipoma, and this point is important as well, in a young male who is fully HLA matched donor with no other available kidney donors. So what happened is a surprise, and I thought this picture could be like describing how I felt, that post-operative, due to some surgical reasons and due to, of course, a better surgical reevaluation of the situation over there in the theater. So they ended up with doing laparoscopic left kidney nephrectomy. I mean that they took the kidney with that's not having the angiomyolipoma. So in a way or another, it was a good news for the recipient that we will know there is no need to be worrying that much about getting a recipient with angiomyolipoma and giving him immune suppression that could be accelerating malignant transformation, and about like pushing mTOR inhibitor, especially in a patient like this who is going for a second transplant, so he is not of a low immunological risk. Okay, so we ended up that the donor is left with a principal right kidney that's having the angiomyolipoma, and all through since the nephrectomy, he is showing a stable GFR that's above 60 with no hematuria, and also with the radiological follow-up for his angiomyolipoma, there is no increase in size in number by ultrasonography follow-up, and he's doing fine. So again, just to remind us, what is angiomyolipoma? Actually, angiomyolipoma, and this first information actually is the thing that made me think about going for this talk, that angiomyolipoma is a very common finding that you might encounter during a kidney transplant workup, because actually it's the most common benign neoplasm of the kidney. Angiomyolipoma could be happening in either one of two settings as a part of a syndrome like tuberous sclerosis, for example, or a sporadic angiomyolipoma. So what is sporadic angiomyolipoma? Sporadic angiomyolipoma, it is an angiomyolipoma of not of a great significance. It usually happens in middle-aged females, and it's often large, though single, unilateral, probably on the right kidney. And there is a reason for this sex predominant for the females because of the high expression of the hormonal receptors on the tumor. And that's why during pregnancy, for those patients, if you can call them patients, who are female patients who are having sporadic angiomyolipoma, it's very important to keep an eye that angiomyolipoma could develop and could be easily ruptured or bleed during pregnancy. And on the right-hand side, you can find this very nice picture of angiomyolipoma. And of course, it is not the graft, because again, we said that for this patient, we took the kidney that's not having the angiomyolipoma. So what is tuberous sclerosis? I mean, we have discussing tuberous sclerosis a lot, and actually it is of value to remind us what is tuberous sclerosis, because actually most of the workup was like evaluating that this angiomyolipoma was a sporadic angiomyolipoma and it's not a part of tuberous sclerosis. So tuberous sclerosis is one of the autosomal dominant multisystem disease that is characterized by the development of hamartomas. What's hamartoma? Hamartoma is a normal tissue of abnormal configuration, and this tuberous sclerosis actually it happens because of suppression of what's so-called tumor suppressor genes. There are two tumor suppressor genes, tuberous sclerosis complex 1 and tuberous sclerosis complex 2, and because of this suppression of those tumor suppressor genes, this disease develop. And this also applies for a similar disease that could like confuse you with tuberous sclerosis and sometimes, which is von Hippel-Lindau, because von Hippel-Lindau, as well as we all know, is due to the suppression of another tumor suppressor gene, which is von Hippel-Lindau gene. So for this tuberous sclerosis, it is characterized by the multi-system development of hamartomas in many sites of the body, including the brain, the kidneys, the lungs, the skin, and the heart. So when you have a patient with angiomyolipoma, you have to go and search for the presence of any lesions, any hamartomas in those 5 sites. Tuberous sclerosis associated renal angiomyolipoma are usually small, multiple, and they are associated with cysts. And if it is associated with cysts, this is like a sign that of poor prognosis. So Generally speaking, end-stage kidney disease is not a common scenario, is not a common ending that you can see in tuberous sclerosis, except if there is a severe renal involvement. I mean, a lot of hamartomas in the kidney with a lot of cysts as well. Angiomyolipoma is considered the most common renal cause of retroperitoneal hemorrhage after, of course, after renal cell carcinoma, and that's why again we are dealing with the donor and the recipient in a very cautious way, because you are going to leave some one of them with a lesion that could easily bleed again, because it easily bleeds. So, what are the alarming signs for angiomyolipoma? Okay, we are understanding that there is some difference between the sporadic type and the syndromic type, or the tuberous sclerosis associated type. So, one of the indicators, or the red alarms that you should consider about going for some intervention in this angiomyolipoma is the size. And the cutoff, most of the literature are considering a size more than 4 to 8 centimeters as a significant size, and one that you should really worry about. And if there is any hematuria, any suspicion of malignancy, and any signs of rupture as well. Here you can see, of course, this characteristic skin findings of tuberous sclerosis, the shagreen patches, and the angular fibromatosis is very characteristic. And actually, I got it 3 times in my board exam in the 3 parts. I have there is some psychological connection between me and this disease. I like it a lot. Again, finally, and this is one like a challenge for me. So how you can just put a diagnosis of tuberous sclerosis for a patient? So it is a matter of criteria. On the right hand side, you can find there are 2 types of criteria: major criteria and minor criteria. So if your patient is having 2 major criteria, or 1 major criterion and 2 minor criterion, so you can just tell that this patient is, yes, having tuberous sclerosis complex. If the patient is having 1 major feature and 1 minor feature, so they call it a probable tuberous sclerosis. And if he is having only 1 major or 2 minor, so it indicates, or you can call him like having a possible tuberous sclerosis. And actually, the significance about this point is that some literature are considering that it is like an evolving disease. So the lesions of the disease, it increases in number, it increases in size, it increases in the sites that it targets. So you have to keep an eye on patients who are even having like just 1 major feature, or even just 2 minor feature. You have to keep an eye on those patients, because most of them at a time they will develop the full blown picture of tuberous sclerosis. So this is like a flowchart algorithm that we followed. I went through the literature, so I found that there were, I think, a paper in the Indian Journal of Nephrology. It followed this algorithm. They did not write it the way it is. We just concluded it. So first of all, you encounter a kidney donor with angiomyolipoma. So this is the first step. So that's the question. Do you have an available other immunologically comparable kidney donor? If yes, so you cut it short, end of story, you reject the donor with angiomyolipoma, and that's it. If no, I mean, there are no available comparable kidney donors, like the situation of our patient, so you have to go for a more descriptive analysis of this angiomyolipoma. Is it asymptomatic? Is it a small one below 4 to 8 centimeters? Is it a sporadic angiomyopoma and not like a part of tuberous sclerosis? If yes, so we can go and accept this donor, but after proper counseling. Okay, so, and this is like an intermediate situation you might find yourself in, which is an an angiomyolipoma that is asymptomatic and probably sporadic, but a big one. which is more than 4 or 8 centimeters. So it needs to rediscuss the case again with your multidisciplinary team, with the nephrologist and with the urologist, the surgeon who's going to deal with this lesion, ensuring the donor and the recipient safety. And again, we are considering the same options that we mentioned before, which is again to transplant the graft with the angiomyolipoma or to excise it, which going for either the in vivo excision or the ex vivo excision, or going for angioembolization. And this picture, I was really having this sensation of a doctor who's dealing with the graft and walking in a minefield. So if you stepped in a wrong step, all the bombs will blow up, and everybody will get damaged, including the doctor. Okay, so we are going for the final slide and then waiting for your comments and your questions. So the take-home messages are: angiomyolipoma should not be considered as an absolute contraindication of kidney donation. Angiomyolipoma is the most common benign neoplasm of the kidney. Angiomyolipoma evaluation should be done in a comprehensive way, clinically, radiologically, and histopathologically. Because actually, in some situations, the only way to differentiate angiomyolipoma from renal cell carcinoma is going for a kidney biopsy. So a tissue biopsy, I mean. mTOR inhibitors has a role in delaying the progression of angiomyolipoma, okay? And the last thing, which is the different intervention options are to be discussed in an individualized approach according to the situation of the patient, according to the size of the kidney, according to the vascular description of the vessels, how many vessels there are, and which part of the kidney you could be sacrificing if you are going for any invasive intervention for this angiomyolipoma. So we have reached the last slide. Thank you for hearing, and I'm willing to hear any questions and any comments. You are more than welcome.
Thank you, Dr. Ahmed. But we want to know more than cases like this interesting case. Jazakallah khair.
Thank you. Thank you very much. Thank you very much, Dr. Ahmed.
Assalamu alaikum. Thank you, Dr. Ahmed.
عليكم السلام ورحمة الله وبركاته, Dr. Asad.
This is
Yes.
Dr. Sejal. Very interesting case, and as you said already, that this is like we always like consider individualization of our decision case by case, because we have limited evidence about these cases. But my question to you, why you didn't took the donor nephrectomy for the kidney with the tumor itself?
Yes, yes. Actually, and this is not only because of the limited evidence and also because of the limited donor pool. So you are going through this challenge. So the nephrology decision was to go probably for a nephrectomy for the kidney with the angiomyolipoma, but due to some intraoperative surgical challenges, they find that the angiomyolipoma is very, very, very small or very low significance, and as well because of some surgical challenges about the vascular supply of the kidney. So overall, collectively, it was much more safe for the patient and for the graft survival and for the ischemia time to take this the left kidney, the one without the angiomyolipoma.
Okay, for the donor now, any role to put him on mTOR inhibitor? Or you
There are
just keep him on
no.
observation or follow-up?
Yes, yes, just observation. And as we stated, he's a male donor, And female donors are more subjected to more complications, especially if the angiomyolipoma size is a big one. But for a male donor who is under a very close follow-up, we are following up this donor in a very, very, very close way, going for the routine follow-up, even for the clinical examination. We are always telling him to keep a very low threshold for any hematuria, any abdominal pain, and with the radiological follow-up as well. I didn't find in the literature any evidence supporting the use of mTOR inhibitors for donors, but generally speaking, they were considering the use of mTOR inhibitors in patients with big angiomyolipomas and probably those patients with tuberous sclerosis, because mTOR inhibitors could be causing some delay in the progression. But at the end, you will be giving a patient an immunosuppressive therapy for a lesion that is not growing, that is not, the patient is like 37 or 38, and this angiomyopoma has been growing since the patient was born. So if you are considering that this patient, this donor is going to live until the age of 80, so you have to think about in a very wise way about giving someone an immunosuppressive medication with not a very strong evidence. They are suggesting, but not highly recommending, especially if it is like this one, a very, very, very little one, 2 to 4 millimeters, not centimeters even.
If we reverse the scenario and we got like angiomyolipoma in a disease like offer. So do we have like certain criteria in our national program to accept such cases, or we just go by size, and what is our consideration? Because maybe we will get it at any time.
We're updating the transplant protocol, and we will be adding this point about the angiomyolipoma because, again, as we said, it is a common finding, so that one will not be rejecting a donor with angiomyolipoma except after going in a deep analysis and deep evaluation. The point about finding disease donors with angiomyolipoma, I think I read a case study about a similar finding, and they took the graft, and I think its size, again, it was not a big one, and they were considering more to go for again the same options. It didn't differ much, going for an bench excision or an in vivo excision, but they are always considering about going for an invasive procedure and about removing the tumor while keeping up that it is a very vascular tumor. And yes, you can end up by removing the tumor and losing a very big part of the graft.
I think one of the criteria that to be considered is like the CT description, like whether it is like fat predominant or
Yes,
vascular
exactly.
predominant,
Yes,
and
exactly.
not only
Yes.
the size or the site, because
Yes,
if
the
it
more
is more
fat, yes.
vascular, there is the risk of bleeding later on, but more fat is more benign.
Yes, more fat is more better, and this is the good thing about fat in the whole life. The more fat, it is more better. Yes, and it is again of a great. It is a clue. Like its radiological picture is very characteristic also because of the fat content. But most of the literature were supporting more the point of the size. They are always minded about the size. The point of the fat, I think it's also discussed in the issue of the malignant transformation. The malignant transformation. The more fat it has, the less liability to go for malignant transformation.
Okay, thank you.
Thank you very much, Dr. Sajan.
I think you have some question in the chat box, Dr.
Okay,
Friday.
Dr. Ahmed, I will read for you the questions.
Yes.
One long question from Dr. Salim. He has a comment. Honestly, it was a brave decision to take the normal kidney, and the donor has the kidney with AML. Although, as you have mentioned, it was a small size AML. Going forward, how frequently will you advise to follow up the donor? And does the donor has the priority in the future for kidney transplant if he developed end-stage renal disease?
So yes, we are giving this donor high priority. I mean, we have a list of donors whom are given high priority donors, named as high priority donors. One of them is this gentleman. The others were two females. Both of them they are post liver, post kidney donors. So how frequent are we following him up? Actually, like double the normal frequency we are following up anybody. I mean, almost we are seeing him after going for more than 7 or 8 months post nephrectomy. We are seeing him monthly. We are seeing him monthly, and he has like a carte blanche to come at any time because he understands that he's not having, I mean, like a serious issue because it's not right to frighten him or to over exaggerate a thing. But I mean, this is like part of the follow up. We have the time, we have the place, and we have all the information about this donor. And by the way, he's not living in Muscat, but still, we are giving him a priority. Considering about this donor priority to go for a kidney transplant, if he develops end-stage kidney disease, okay, so let me answer this question in two parts. Of course, if God forbid, and this patient, this donor, due to any reason, being a patient with a single kidney, and he develops end-stage kidney disease due to any reason, of course, he has a priority because he is a kidney donor. But on the other hand, I think that the question is about angiomyolipoma, even the bad one, let's call it the bad one and the good one, even the angiomyolipoma, the bad one or the more serious one, the tuberous sclerosis associated angiomyolipoma, it is not that common to be causing end-stage kidney disease except in a situation where there is a very significant, strong presence of angiomyolipoma in both kidneys, a lot of lesions, along with renal cysts, And there is a variant of tuberous sclerosis. I think they call it infantile polycystic kidney disease, tuberous sclerosis, contiguous gene deletion syndrome. And in this syndrome, there is a strong gene mutation that causes that disease, the tuberous sclerosis, to be a very aggressive disease that causes many angiomyolipomas and a lot of renal cysts, starting in the patient in a very young age, ending up with the patient going for end-stage kidney disease at like the second or the third decade. But for such a patient or such a donor with a sporadic, again, as we stated, the incidence is very, 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 very low. I mean, they were only discussing the incidence of end-stage kidney disease for the angiomyolipomas that are part of tuberous sclerosis. But for the sporadic ones, no.
Okay, Dr. Ahmed, another question from Dr. Ayman, the same question, how frequently would you follow the donor? And another question, is it essential to take renal biopsy even with radiological diagnosis?
Okay, so let's go in and answer this question in two parts. The first part, you go for a tissue biopsy or a kidney biopsy in any situation when the current clinical and the serological markers and the radiological pictures are not enough to reach you a diagnosis. But for angiomyolipoma, the thing is completely different. I mean, the sonar is of a very good value, the CT as well, and the MRI, of course. It has a very characteristic finding, but they are strongly recommending to go for a biopsy, a tissue biopsy, if you have a suspicion about is it an angiomyolipoma or a renal cell carcinoma? At that time, or in this situation, yes, you should go for a tissue biopsy. But generally speaking, no, it is not routine. It is not routine, except in the situation of differentiating angiomyolipoma from renal cell carcinoma, or in a similar situation about a donor and a recipient, and you are going to take the graft with the angiomyolipoma and you are going for excision. So if you are going for excision, either in vivo excision or ex vivo bench excision, of course, as long as you are dissecting and removing a tissue, you are going for a tissue histopathological examination.
Okay, thank you, Dr. Ahmed. Another, I believe this is the final question in the chat box. Which immunosuppression increase the risk for malignancy transformation?
Okay, that's a good question and a tricky one as well. So the point of malignant transformation or malignancy in the scenario of a patient who is going for kidney transplantation is a matter of immune suppression as a whole. But there are certain lines that are more liable to predisposing to malignancy, like the CNIs, for example, like azathioprines as well. But again, it is rather a function of the collectively immune suppression. But of course, here the mTOR inhibitors have a good benefit because, first of all, it has an anti-cancer, anti-angiogenic effect. Okay, and in this patient, I mean a kidney transplant recipient with a kidney with angiomyolipoma, it will theoretically, at least, it will add more protection against the malignant transformation of this lesion. But on the other hand, I mean, we should always be like considering the other aspects of choosing your immunosuppressive medication, the immunological risk of the patient, the native disease, the degree of the proteinuria, and what so forth. And let me add one more thing. In most of the case studies discussing similar situations about patients who received renal allografts having angiomyolipoma, I think only one of them, I went through like 4 or 5. I think only one of them, they discussed about using mTOR inhibitors, and at the end, they did not use it, and they stated that the reason was logistic issues. But all 4 other case studies, they did not go for mTOR inhibitors. But in the case presentation, they were discussing it from at least the theoretical point of view.
Okay, I believe this is all what we have in the chat box. I have one question for you, Dr. Ahmed, if you please.
Sure.
About the genetic testing for mutation of tuberous sclerosis 1 and 2. So
Yes.
if you have a kidney donor with angiomyolipoma and it is solitary, classic, not associated with any tuberous sclerosis features, normal examination, normal brain MRI, everything is okay. So when you proceed to consider the genetic testing for the tuberous sclerosis 1 and 2 genes?
I do not have a clear, straightforward answer for this point, but as you stated, it is over very good value. But generally speaking, you are always going for genetic testing for equivocal cases. I mean, I'm going to get another example. If you have a patient, and this is very common that we are always seeing every now and then, a patient with autosomal dominant polycystic kidney disease, which is the most inherited kidney disease. And he has a brother or he has a sister, one of his family members, who's willing to donate. So are we going to reject the donor? No, you're not going to reject the donor, but you are going for an age matched approach to investigate the presence of autosomal dominant polycystic kidney disease in this donor. And it depends on the age. It depends on the age. The older the donor, the less invasive you are considering. I mean, for donors who are like above 40, you will just be going for ultrasonography. But for young donors, and this is like could be an answer to such a situation you're talking about going for genetic testing. For young donors, yes, you can consider you can consider going for genetic testing for those donors. For donors who are potential donors for a patient with autosomal dominant polycystic kidney disease, and you want to know if this donor is going to have the disease or not. So if the same principle applies to a donor whom we have a suspicion about the presence of tuberous sclerosis. But the point is that genetic testing, and this is like my personal opinion, I'm saying it in a very clear way, that yes, I agree that, and this is like off the record, that going for genetic testing in those patients who were named as probable or possible cases of tuberous sclerosis, and they are considered as potential kidney donors, I think, yes, I would go for a genetic testing. Yes.
Okay, thank you. So
Thank you.
now to Professor Isa for comments and remarks.
Yeah, sure.
دكتور عيسى اتفضل.
دكتور فادي ممكن تختم لان الدكتور عيسى اعتقد he have to leave فمش متاح
اوكي.
معاه.
طيب اوكي، طيب لو الدكتور ابراهيم معانا او الدكتور احمد عتريس يختم.
ايوه بيتصل. ايوه.
الدكتور احمد اتفضل.
سبحانك اللهم وبحمدك اشهد ان لا اله الا انت استغفرك واتوب اليك. بسم الله الرحمن الرحيم. والعصر ان الانسان لفي خسر الا الذين امنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر. جزاكم الله خير.
شكرا دكتور احمد. شكرا جزيلا. تصبحوا على خير.
شكرا جزيلا.